So today we are discussing ischemic heart disease. If we analyze the term, ischemia is the lack of blood supply. So our terminology refers to heart disease caused by the lack of blood supply. So if we look at this topic, it is a very, very important topic from an underwriting and from a claims perspective. Two of the four SCIDEP definitions, SCIDEP, for those who are not familiar with the term, is the Standardized Critical Illness Definition product. Two of them relates to ischemic heart disease. Heart attacks or coronary thrombosis or myocardial infarction, that all relates to the blockage of an artery causing death of heart muscle. Or then coronary artery bypass grafts, that is the intervention, the operation to bypass a diseased part of a coronary artery in order to restore blood flow. Underwriting, unfortunately, very, very common. People have high cholesterol, they have blood pressure, they're overweight, they don't exercise, they smoke, they're diabetic. So the risk for coronary artery disease, specifically in the South African population, is actually very high. So first we have to look at the anatomy to understand the pathology. So if we look at the coronary artery circulation or the heart's blood supply, the heart is supplied by the two arteries that come off the aorta, the very first branches that come off from the aorta once it's left the left ventricle is the right and the left coronary artery. The left coronary artery immediately forms the left circumflex artery and the left anterior descending artery. So those three main branches, the right coronary artery, left circumflex, left anterior descending, are the main branches supplying the heart muscle. Now, these three branches have lots of little branches, but for our purposes, we need to know the three main branches. If we look at the pathology, if we open up an artery, we might find some plaque in the artery. Now, plaque is a fatty deposit formed by cholesterol and then getting foam cells and inflammation and so on. And this plaque grows bigger and bigger and it obstructs the flow in the coronary artery. But it's not just the plaque and the physical obstruction. If we look at a section of the coronary artery, we will see that the plaque obstructs the lumen, but there is a thin cap over the plaque. But if this cap ruptures, blood forms a clot and it obliterates the lumen of the coronary artery totally. And of course, that is how a heart attack happens. The disruption of the blood flow leads to death of the heart muscle. Now that has a couple of complications. The one is arrhythmias, which could kill the patient, or the muscle can be so weak that the heart actually ruptures and that leads to death. So those would be your death claims. On the other hand, if you have medical intervention, if people have access to good medical care, they can go to the accident and emergency section and they can be treated quickly. They say time is muscle, so if you restore the blood circulation quickly, the heart muscle will have much less damage and the person will survive and will have minimal impairment of the heart muscle afterwards. Now, if we look at the definition of a heart attack or the markers of heart attack, there's always the clinical component. And the SCIDEP definitions refer to compatible clinical symptoms. Compatible because it's not just always the classical picture. Women can have pain between the shoulder blades. Diabetics can actually have a painless heart attack called a silent heart attack. But the classical symptoms are the crushing pain behind the breastbone, sweating, nausea, and collapse. Then we have the second component, which is the cardiac markers, troponins. Now, troponins is a marker of heart damage, and we'll get back to that in a moment. And then, of course, the ECG changes. So those three components always are involved in a heart attack. The SCIDEP definition was developed to standardized definitions in the market to make it easier for people to know when they will be paid for a heart attack, because there's a definition that says of defined severity, specific severity. So it is possible that somebody could have a mild, very mild heart attack, and his cardiologist could say, you have had a heart attack, but it would not meet the insurance definition. So troponins are our heart markers. They are the markers for heart muscle damage. We get troponin T and troponin I from the heart. There is also troponin C from the skeletal muscle, but that's not important in the context of our myocardial infarction. The troponins have a typical rise and fall. If we do blood tests, they first go up and then afterwards they go down. But very often in the clinical setting, they take one blood test, they do the ECG, and if there's a heart attack in process, the patient would just be wheeled straight into the cath lab and he would get his stent. Just on the units, there's been a change in units. Previously, it was nanogram per milliliter. These days, it's the high sensitivity troponins, and it is expressed in nanograms per liter, and there's a conversion factor of 1,000. Obviously, from milliliter to liter would be times 1,000, and the other way divided by 1,000. ECG changes, typically ST segment elevation, and then we also have ST depression in the other leads. But there you will have to go on the cardiologist's interpretation, or you can ask your CMO to help you with ECG reading. Then on the claims side, there are some procedures that are covered on the claims. Stents. Some companies would cover one stent only, some companies will cover 2 or 3, and some companies will not limit the number of stents that they will pay for. It's best, if you're a claims assessor, to just check your contract. The coronary artery bypass graft is also one of the SCIDEP definition, and that is normally where the heart artery is so diseased that they cannot just put one stent in, very often in diabetics. So what they do is they take another vessel, either the vein from the leg or the artery in the arm, or the artery on the inside of the chest, and they use that to bypass the diseased part of the coronary artery. Stents, very common. It means that you put a thin little catheter, open up the diseased portion, and put the stent in to restore the flow. On the other hand, coronary artery bypass, much bigger operation. They have to open up the chest and they have to harvest the artery or the vein. That is really complex surgery. From an underwriting point of view, now that we know what the end result and the claims are, how would we underwrite myocardial ischemia or angina? We look at it from risk factor perspective. Cholesterol, glucose metabolism, overweight, smoking, exercise, not always so easy to quantify, but exercise, lipids, and so on. And many of our reinsurance manuals have very, very handy calculators where you just punch in the various risk factor values. Once you've had a coronary event, you're immediately in a high risk for the next one. So on benefits, critical illness, income protector, and capital disability, be very careful on how you underwrite your coronary artery disease clients.